I am grateful to INASL, Dr. Duseja, for inviting me, and also to Jess for having laid down a very clear roadmap. I bring greetings from ILBS. I have nothing to disclose, and I'll try and just cover 2 slides with respectfully with Jess. I would say the pre-ACLF and the APSL definition covers more than 5, so it's not too early. It may be early, but not too early, and that's where the easel comes, and that's where NACSEL comes, and this journey continues. But nevertheless, the whole idea was, and the initial initiator of these discussions was Risha and Patrick way back in 2004 when we started in a Jaipur meeting. So the whole idea is the spectrum, and it continues. But let me tell you the second diagram of this same harmonizing definition part, and what we thought of reclassifying, and this is undergoing evolution, is type A ACLF and type B ACLF. And this is to simplify that if you have the Japanese definition is almost the same as a parcel, you use type A, means it is a liver based therapeutic injury, and it can be grade 1, 2 and 3, and this gives you based on ARC, which has 4 of liver and 1 of kidney. So this is one way. The patient comes, you say type A ACLF, means liver dominant, and you can say type B ACLF, which has the Chinese, the NACSEL and easel, which you have maybe single kidney or 2 organ or more than 2 organ failure. This is to simplify and say this guy has not come with liver failure, maybe he has come with, but this may be simplistic, but just to give you where we think the harmonization of definitions can take place. I'll give you one simple message of prevention of ACLF. Then in the emergency, if a patient comes with high bilirubin and ascites and all, and first time, please do not give NSAIDs, contrast, unnecessary biopsies are not planned, don't do invasive procedures, unnecessary taps or even albumin, because the liver cannot clear albumin if the bilirubin is high, and I'll show you. Detect the patient at source, don't wait till sepsis, and prevent organ failure. Don't use renal toxic doses because kidney is very sensitive with high bilirubin and bile acid. My first message, and this is for all postgraduates, is the nutritional prescription. You need to give good calories. Unlike in a ICU shock patients where you have less than 70%, here you need more calories. Change to positive nitrogen balance. Nitrogen balance can be changed in 3 days from a negative nitrogen to positive nitrogen by giving fats. We have shown this earlier. Then you need to give nasogastric feeding if the patient cannot take food. Very often they have distaste, so put in a tube and feed them. And of course vitamin. So the calories are an important part. Now this is what I was talking about bilirubin. The normal bilirubin have one position where you can have albumin, and this is human mercapt albumin. But the moment the bilirubin level is high, you will have much more of bilirubin. So bilirubin will bind to all 3 sites available. So one of the thing is endogenous albumin is modified. Second, bilirubin is bound. The modified albumin is HNA1 and HNA2. HNA2 is where irreversibly the 34 hydryl group is changed. So now it is a useless toxic albumin. And this happens, the more you give external albumin, the more it becomes toxic. So albumin in ACLF is dysfunctional. I would recommend you to read one of our reviews. I don't have enough time, but just to tell you that in these patients a lot of nitrosoalbumin forms. Nitrosoalbumin prevents clotting. So you have coagulation disorders. So be careful when you give albumin in a deeply jaundiced subject. So the basis is, and I'll come to it again, that don't merely replace albumin, and try and remove, then give fresh albumin. How do you do acute insult mitigation? Alcohol, you may give steroids. I'll show you autoimmune steroids. If there is a drug-induced injury, you may dialyze or give plaques. And Wilson, you can do plaques. Antivirals, maybe ribavirin, it's not so sure. Antibiotics and antifungals. Now this is an important, very important data. You have a patient of severe alcohol-associated hepatitis, apologies to Dr. Alexander, and jaundice, INR and ascites. Now this is the data which Rakhi prepared from 1200 database from ARC. Of the total number of patients, only 30% were eligible to get steroids. Of 30%, 44% got really response, and that total is 14% of the patients are eligible or are responding to steroids. 86% are out. Who will respond? Very easy. If you use the ARC score, those who have an ARC score of less than 10, they will respond to steroid. Those who have an ARC score of less than 10 have a benefit on survival. ARC score is simple, bedside. So ACLF means jaundice, coagulopathy and ascites. If you are using steroids, you may try and evaluate ARC score. But as I said, 86% are not benefited. So we had done this study of FMT neck to neck with steroids, and this we published thanks to Dr. Shastri, where FMT was as good if not better in improving survival than prednisolone with less infections and organ failure rates. You can try that. This is autoimmune hepatitis, where steroids given to a patient with MELD of less than 25 has advantage, not above that. I'll briefly come to some new thoughts. Before that, if a patient has HBV reactivation, his DNA levels are generally above 10 raised to power 5. You give nucleoside analogs. Nowadays we are giving 2 nukes together, and a reduction in 2 log in 2 weeks is beneficial. Then you have concept of acute portal hypertension. Now in ACLF there is a massive rapid cell death with massive release of cytokines, stellate cell activation, endothelial dysfunction, impaired vascular relaxation mainly because of hyperbilirubinemia, high bile acids which cause vasodilatory effect and reduce MAP. So a patient with cirrhosis already has portal pressures of let's say 12, 15. Now you have ACLF. So further acute rise, within 7 to 10 days there is a rise in portal pressure, and this leads to high risk of ascites, hepatorenal syndrome, variceal bleed and encephalopathy. So from 12 the pressure may go up to 20 plus within a short period. Body is not used to. So acute portal hypertension in ACLF, if there are no varices, end of 4 weeks, believe me, some of them will have large, some will have short, small varices. So this study, which Manoj published few years ago, those patients who had carvedilol compared to placebo, there was an improved survival at 4 weeks, and there was reduced AKI and SBP. So don't let the portal pressure remain high. The second important is patient has grade 3 tense ascites. This is an anteroposterior abdomen, not side to side abdomen of cirrhosis. Very tense. Now in these patients, the plasma renin activity is normally up to 4, is 20, 30, 40, very high plasma renin activity. Then in such patients with high PRA, if you do TAP, please do modest volume, 3 liters to 4. We call it MVP because rapid decompression of intra-abdominal pressure will lead to PICD. So remember this, and you give albumin in this situation like others. Rakhi has briefly and beautifully in her lecture mentioned about AKI, but AKI ACLF guidelines are released. She is the lead author, and in this there are liver related causes for kidney injury, kidney related causes and drugs related causes. I recommend you to read, I don't have time, but AKI in ACLF is huge. How do you manage? So you have a patient of newly diagnosed AKI in ACLF, you will give volume and albumin. Well, few of them may respond, maybe 10 to 20%. If there is no response, start terlipressin, don't wait for 48 hours. This is the Eat Early study in 12 hours. If there is a response, it is good. If there is no response, and response may come in only 1/3, then you prepare for the renal replacement therapies. This is the Eat Early study, where if you start early enough before the vasoplegia and other things develop, response can be better. Coagulation failure is an important part, but do not correct INR with FFP if there is no bleeding. You put load and you cause lung injury. Correct if needed by Rotem. Try and keep fibrinogen well, and don't give platelets or fibrinogen unless you are putting in a needle or doing a procedure. The next part is about sepsis very briefly. I want to show this important diagram. Liver injury, first say cell deaths, DAMPs, exin, all these lead to production of SIRS. Now SIRS can go to sepsis. You are waiting all the time for sepsis, but remember SIRS directly can lead to organ failure directly. So remember, halting inflammation is important, and this is the golden window. Anand had done a good work by showing if you give norfloxacin early, you might improve 90-day survival compared to placebo. What happens in SIRS and sepsis? There is a SIRS component which is the driver. In 12 hours your neutrophils become non-functional, they live long. 24 hours monocyte lose all their HLA expression. Impaired neutrophils, monocytes, dendritic cell, and you will be having infections coming. So sepsis is a consequence of liver failure. This is what we believe. This was a study. I just want to show you that patients with cirrhosis, when they got acute insult and ACLF, neutrophil dysfunction was there, which led to sepsis and other complications. If you give GCSF to them, neutrophils improve, new neutrophils form, and you can prevent sepsis and all other organ dysfunction. Now this is a very interesting recent study. What about fungal infections? Those who have neutrophil count above 70 as total number, those people have more fungal infections. Rather reverse of thought, we thought neutrophils may be good, but 70% means these are neutrophils which have not improved. Those who have received earlier steroids have more of fungal infections, those who have received antibiotics more. And Dr. Sunil Taneja and the group from PGI had shown preemptive antifungals may be helpful. I'll briefly discuss about liver support devices. One, you have got adsorption devices and one is exchange devices. So heme adsorption removes water soluble molecules and cytokines from 5 to 60 kilodaltons, and DP mass can actually remove both bile acids as well as bilirubin. And this study which we published very recently showed that when you give, compared to standard therapy, heme adsorption at day 7, there is less of bilirubin, more bilirubin is decreased and more bile acids, and organ failures are less, infections are less compared to even plasma exchange. Here you can see bilirubin reduction is maximum with heme adsorption, although bile acid removal, although about 50, was not enough. This is to show you a new concept which is emerging of mixed modality or multimodality artificial liver support. So what you can do is plasma exchange plus heme adsorption or hemofiltration, or you can combine any other modality. If you have 2 or more modalities combined, maybe you will remove more of bilirubin, bile acids, and HRS can be prevented. Therefore, one more time, it is important to remove toxic albumin rather than keep on pumping. This is shown by Dr. Jalan's group, where the The studies have shown that dialysis is a new method where they are removing the albumin after toxin and albumin, as the bad albumin is removed, then they introduce new albumin which might delay organ failure. A concept of ACLF reversibility is, if you have a patient who from earlier ACLF criteria now has bilirubin of less than 5, INR of less than 1.5, then you may have a resolution of ascites at end of 1 year, and those who have a reversal have low BMI, better WBC, albumin, platelets and ARC score. Liver transplant is a good option. Our main aim is to convert. From day 0, only 34% are transplant eligible. In first 4 days, Ashok has shown that 63% can be transplant eligible. This is my last slide to show you. When a patient of ACLF comes, try and find etiology. If needed, give steroids or antivirals. Prevent sepsis. Give good nutrition. Prevent organ failure. If needed, plasma exchange or heme adsorption. If the ARC score is above 10, MELD is above 30, straight transplant. Wait till day 4. If the patient is improving, you might do with medical therapy. It may be reversible. If it is increasing, emergency transplant. If the patient has come with 2 or more extrahepatic organ failures, you may need to stabilize. If he improves, early transplant. If not, and maybe if he has 4 organ failures, you will think it is a futile exercise. With this, I invite you to the International Liver Cancer Congress at ILBS and drills an Apostle 2025, and hopefully we all can join the ARC and other consortia which Jess had told. Thank you.